I think some more people will join. I'm not sure. You might want to text your friends and say, hey, hop on this Zoom with us. We'd really appreciate it. But my name is Kayla Sanders, and I am the Genesis Board Liaison. We've got two presenters today, but three Genesis Board members that are here with us. We've got presenters Erin McDonough and Amy Dunleavy. Dunleavy. I always mess it up.
Yeah,
Dunleavy.
Dunleavy,
Dunleavy.
but it'll change in
Dunleavy.
July, so it'll
Yeah.
end of June,
Okay.
so it'll be
Sure.
different.
And then we've got Emily Viverberg. And also, Kristen Peterson is going to join us here in about 2 seconds. But I'm just going to right away hand it over to Erin and Amy and can get started.
Cool. Amy, are you gonna share
Yeah,
the
yep,
slides?
I'll
Okay,
go ahead
very
and
good.
share it
Sounds
over
like
here.
Hey Jenna, what year in school are you?
Um, I'm a P3.
P3? Cool. All right.
Sorry, I can put my video on so I don't look just like a black screen.
Sure. Sounds good. You got rotations coming up here shortly. Excited?
Yeah, I'm a part of the Lappy program, so that's fairly new at Iowa. So I'm excited for that.
Cool. That's awesome.
I've heard a little bit about that recently. Yeah, very cool. Because are you six rotations there then at the hospital or with UIHC, or is it five?
It's 5 for the
Five.
Lappy
Okay.
program, but
Very
I was
good.
lucky to get all but one UIHC.
Oh, well, very exciting. That'll be
Cool.
hard to believe it's just a short little, under 10 weeks away right now. Is that?
Yeah, I don't want to
Wow.
talk about it. It's not here.
An
Just
exciting
a
time.
matter of time before it'll be almost 2025 when you're graduating too. So
Yes.
those last couple months, that last year goes by pretty fast.
Oh
It
yeah.
really does. Tonight we're going to talk a little bit about what types of things are going on in the profession, what is some of the new innovative programming that pharmacists are getting involved in, as well as what are some of the opportunities you can take to create new services delivered by pharmacists in settings that you work in. I have a little bit of a background in a community-based pharmacy practice, but now work within the colleges of pharmacy and dentistry. Erin and I will talk to you a little bit about both of our backgrounds and why these different areas are important to us and experiences we've had in these areas. But we'll talk a bit about identifying opportunities. How do you get funding for those opportunities? How do you make those sustainable? And what are ways to generate additional revenue in a pharmacy setting outside of the traditional dispensing model. Feel free to definitely interrupt, ask questions as you have them. We really want to encourage a discussion here rather than giving you more of the in the seat lecture. So in terms of my background, I graduated from the college in 2020, so was our COVID year, and then went on to do a residency with the University of Iowa's community-based program, and I was at the Osterhaus Pharmacy site in Maquoketa, Iowa. And so during my year, I spent a lot of time rolling out some of the COVID vaccine and testing protocols, but also did a year-long project on how to better collaborate with practitioners in our community, really focusing on what were the best modes of communication to integrate us into their workflow, as well as then there were a number of MTM services we were providing beyond just your usual outcomes, Marixa. We were doing some pharmacogenomics education. And so really navigated that over the course of the year. After graduating from my residency program, then I went to practice in an independent community pharmacy in Columbia, Missouri as their clinical service coordinator. And so had the opportunity to develop a few new enhanced services for the two pharmacy sites I was involved in. And then in May of 2022, I came back here to the University of Iowa and now serve as a clinical assistant professor in both the colleges of dentistry and pharmacy. And a very unique position with that professorship in that I also run a full 40-hour-a-week pharmacy in our pharmacy, while it's classified as a retail pharmacy, anybody could come in, pick up their prescriptions for us. We do a lot of working directly with dental practitioners. So have services that we provide, including point of care testing, patient consultations, medication, identification of what type of product would be maybe ideal for a patient, as well as compounding. So have a little bit of service development that we do here within the College of Dentistry.
Cool. All right. Jen, I actually have another quick question too, before I kind of dive into my background. What do you have an idea as to what you kind of are leaning towards as as you go through school, getting an idea of the different areas in pharmacy? Do you have one that kind of resonates with you?
Yeah, so basically my background is community and hospital, but I've worked currently at the ambulatory care. But looking forward, I'm really keeping my eyes open, but I've been interested in psychiatry or am care in the hospital setting or pediatrics. So, but my eyes are
Cool.
open. I can open mind.
Sure. That sounds good. Thank you for that. So background on myself, I graduated in 2021, it's just a year after Amy. I was planning on doing a residency my entire upbringing in pharmacy. My dad was an owner of Town Crush Pharmacy and involved in pharmacy space for a long time. So it was kind of my entire childhood too. And so it's like, hey, you're going to do a residency and then you're going to have opportunities open for whatever you want to practice. When I was on rotations, I decided I couldn't find a residency that was going to be one that resonated with me, that was going to be something worth my time and my like what I wanted to grow professionally and personally. So I opted out of doing residencies. I actually did that in like December of P4 year. So kind of scary because that's when everybody else is kind of figuring out which ones they're going to do. And the reason why I did that was because I was at a pharmacy in Arizona on rotation. It's called Potter's House Apothecary. And they were introducing me to not only compounding pharmacy, but functional medicine or integrative functional medicine, natural medicine, all these different opportunities that exist in the patient consultation space in natural medicine. I was like, that's super cool. I think that we might have a space for that in Iowa. So I kind of pitched that to the current owners of Towncrest, and they're like, all right, cool. Let's, if you think you can do it, let's run with it. And so I obviously didn't do a residency. And after graduation, I had this whole plan of starting this wellness apothecary. So for the first couple months after graduation, I was almost like a subcontractor because I actually designed the building that I'm in right now. So we purchased this building, gutted it out completely, and I got to start from scratch to design my own pharmacy, what I wanted it to look like. And well, all at the same time of reaching out to providers and making education in that space about what my vision is and how we can collaborate and, what a pharmacist's role is in that space. Really, preaching to them why a pharmacist is valuable, which is something that unfortunately we have to kind of express to a lot of providers and lay people and friends and family and patients throughout your entire career is making them understand what you're doing other than putting drugs in a bottle. And we'll kind of talk later on about why I don't even want to have drugs at most of my pharmacies and what that might look like in the future. But it ended up taking off really, really fast. And a lot of people are really interested in this natural medicine stuff. And we started doing a lot of consultations, and that started off actually with Men's Health. And the way that actually started was I just blasted people on LinkedIn. I'm just like, hey, I'm doing this, I'm doing that, I'm doing this, I'm doing that. Who's interested? I'll get like a 5 to 10% response rate. So 90% of the time I'm not getting responded to. And that's when I completely just dropped any, I thickened my skin, I guess, is I don't care if people don't respond to me. I'm interested in this. I think this is cool. I think you guys should be interested in it as well. And so, it's all numbers game. So I could reach out to 5 people and all of them would say no or not respond. And if I just gave up, then nothing's going to happen. Nothing's going to come from it. But I reached out to like 1,000. So you're bound to have somebody respond. And of that 1,000, a handful of people did respond. And those ended up being kind of the people that turned the business into what it is today. And at first it was actually an MD at a urologist at the University of Iowa. And she was like, "Oh, this is really cool. I work at the men's health clinic and I have a lot of patients with erectile dysfunction." And I'm like, "Oh, well, erectile dysfunction actually is likely oftentimes due to being overweight, sedentary, and having a poor lifestyle behaviors with poor nutrition and lack of physical activity. I think we can work on that." And then she started sending me all her patients so I could talk to them in the outpatient setting about lifestyle behaviors, nutraceuticals, and how they can help, making sure that they're professional strength and getting somebody guiding them to getting and purchasing a correct form of an OTC, having these discussions about diet. And I always said from the get-go, I will not do this for free because oftentimes in pharmacy, what you'll find out is we just give away things for free. Services, not drugs, but technically we do for reimbursement, poor reimbursement. But typically we're just like, hey, let's spend 30 minutes talking about lifestyle and I'm not going to bill you a dime for my time. And then that's not a sustainable business model. That's not sustainable for pharmacists or for pharmacies. And so I just would be upfront with patients and with their providers. This is what I'm going to charge for an hourly rate. This is what you should expect if you're going to do a consult with me. And I always did that with the provider so that the provider would be able to share that information with the patient. Because what I found out over time was if I say one thing before the doctor or before the referring provider says one thing, it doesn't resonate as well with them as if the provider literally says the exact same thing that I was going to say. And then they say, hey, go see Aaron because he's going to help you with this. They're like, oh, that's a good idea. So I would actually use the provider as doing my dirty work of telling them what the price would be. And then they would be like, okay, cool. If you think it's good for me, then I'll go see this Aaron guy. And that turned into doing so many different specialties from men's health to pediatrics with ADHD, autism, OCD, to women's health with hormones, to all sort of even vets with a lot of pets and dogs and cats and various animals, to a lot of psych actually. And I just what I did with that nurse practice or with that MD at the men's health clinic, I just replicated that with all these different practitioners. And I was like, hey, this is something I do. This is something I'm passionate about. This is how it works. This is why you should be interested in it. This is why your patients would benefit from it. And this is what I charge. And I always did that kind of same cycle over and over and over again. Recall, I would also send that same message to 100, 200 people, expecting that majority of them didn't want anything to do with me. But then I just kind of latched onto the people who were interested. And that grew into such a cool service offering that I never thought I would have been in as a pharmacy student. It was just something that I was like, hey, this is cool. I'm interested in it. But really understanding how to persuade and convince another practitioner about why a pharmacist is valuable in that position was what actually turned the business into being a successful business. So that's kind of what I do today. And I do a lot of different things, including our Cost Plus pharmacy. And I'm doing a lot of education in that space about why insurance isn't good most of the time for prescription medications, specifically generics, and educating about why we can save or how we can save people money. But we expanded our pharmacies. We have 8 total pharmacies throughout the state of Iowa. I do a lot of education with our staff too, because at the end of the day, my favorite thing is actually educating, whether it's educating a provider, a patient, a student, or providing my own staff about how we can then teach other people the same thing that I have this vision of, how I can teach my staff to then teach their patients, because I can't reach every single patient in the state of Iowa. I can't reach every single state or patient across the states, the entire United States. It's educating those people to then educate their constituents. I'm also a shareholder of Seguridad. Seguridad's really cool. It's also known as Choose My Pharmacy. That is going to be our metrics of how pharmacies are held accountable for reimbursement when provider status does hit. So Seguridad's going to be really cool and really instrumental in how pharmacists can bill for their time. So more to come on that in the future. I'm really excited about that. And obviously our Cost Plus pharmacy, you may have seen a little bit of that with Mark Cuban's Cost Plus, but we're bringing that on the local level and just making it so it's a lot more transparent and you're working with your local pharmacist.
Okay. So, I'm going to talk just a little bit about how we can identify patient service needs, and then how you can really start to initiate some of those projects through the assistance of various pharmacy organizations, public health organizations, and working with other individuals within the community, such as your colleges of pharmacy and schools of pharmacy. So, in my experience, in the two pharmacy settings I worked in, we really looked at our patient population and were there disease states that were prevalent among these individuals? Who were our patients that were on the most medications, and what were those types of medications they were on? What could we infer from that regarding their disease states? What could we do to help provide education about that disease state, potentially help them come off medications or prevent progression of whatever disease was present for them. So while I was at Osterhaus Pharmacy, what that looked like is we identified that diabetes was something that was very prevalent in our patient population. And being in a very rural area, we had individuals of varying levels of health literacy, as well as we had individuals who really didn't have a lot of great access to a pharmacy, at least in it being that they could get there every day or that they could get there kind of at the drop of the hat. Some of our patients were coming in, driving 15, 20 minutes to come and use our pharmacy. And so we were able to see with the Iowa Pharmacy Association that they had some funding available to look at diabetes education and track how many conversations were you having with patients. With those conversations, what did they look like? And then further steps could go to establishment of a formal accredited DSME or a diabetes education course that would then be billable to things like Medicare and Medicaid. And so the way we kind of rolled that out was we first identified our patients who were on something like metformin, on an insulin, on a GLP-1, any of our other diabetes medications, and compiled a list of those patients. From there, we were able to put some flags in their profiles to put anytime that they called or anytime that they were filling a medication, just a little note in their basket at pickup that a pharmacist wanted to be involved in a conversation there with the patient so we could find out how they were doing, were there gaps in knowledge that they had about their disease state, were there things we could do to help support them. And from there, we were documenting through the use of what we called e-care plans, what those conversations looked like, compiling data to see, okay, we noticed 15 patients have no idea how to use their pen, their insulin pen. So, yep, they need insulin, but they don't know how to use their pen. So their diabetes is continuing to be unmanaged. They're experiencing complications. They're headed to the hospital for glycemic events or lack of glycemic control. And we were able to see things like, okay, actually, I've got a bunch of patients who have foot wounds because they can't feel their feet. So we need to help provide additional support in educating on podiatry visits, as well as are they a candidate for something like diabetic shoes. And so we really ramped up our diabetes service offerings with those consultations. So what that looked like for us was consultations regarding medication adherence management. So like med packs, we did monthly med cards, weekly med cards. We offered delivery service. So we helped to expand that to a number of individuals. It looked like diabetes shoe evaluations where we helped with doing fittings and helping people acquire shoes that were appropriate for their foot, appropriate for their needs to try and decrease the amount of wounds that were experienced and provide that nice foot protection. The unfortunate thing with part of these services is we really were probably not charging enough for the service we were offering. So with many patients, we were doing this as a free service or depending on their insurance to reimburse on the conversation. And so we knew it was not sustainable without some sort of additional income. And so by working with the Iowa Pharmacy Association, we were able to submit data that we had collected about what we were doing. And I believe we ended up with a grant of just under $1,000. It was not a huge grant, but helped to provide some reimbursement for what we were doing while we collected that data and information. What I would have envisioned that to continue to look like after leaving my residency is something that they continued to do, charging service fees for anywhere from like, okay, we're meeting to talk about your medications for 30 minutes, so we're going to do a $30 charge for that. Or we're going to do your diabetes shoe consult. Maybe here's a fee associated with that. We're going to see you back in 6 months, see how that's going, kind of get prepped for the next year shoe, something like that, where there was a little bit more hands-on care for that patient, as well as incoming money for each one of those encounters. What I did in the Missouri setting was similar with diabetes education that we were providing, where we charged a flat rate for the diabetes education classes, but also we expanded out into doing remote patient monitoring for blood pressure. And in this space, we were again working with the State Pharmacy Association, where we were able to acquire free blood pressure cuffs that had a Bluetooth component to hook up to the patient's phone. We were tracking our encounters with the patient by just time rather than any sort of metric or outcome metric, submitting that to the Pharmacy Association that then continued to fund the project. And then where it became more sustainable is when we started having conversations with a local cardiology clinic about patients we were seeing of theirs, and making different kind of dose suggestions and regimen changes for those patients. And when they found, wow, this is really valuable, we started that conversation of, okay, this is something we could provide to any of your patients. What that would look like is they need to fill their medications with us here at this pharmacy. We would provide blood pressure cuff for X amount of time that we spend with your patients. You will need to pay the pharmacy X amount of dollars, and so forth. And so it really started out initially just as here's the flat rate that the provider is going to pay the pharmacy. What we were in process of working through at the time I left that particular position was the establishment of a formal collaborative practice agreement, which from the pharmacy side of things was still going to look like the medical provider providing a check to the pharmacy for the services, but being able to bill for the services that the pharmacist was providing on the medical side of things. I unfortunately did not get to see kind of the end result of that, but was something we were in the works of kind of managing. My biggest advice for seeking out providers to work with really was looking at the patient population that we served and using our dispensing software to run a number of reports. We were able to use our dispensing software and run a report that said, okay, who are your top prescribing physicians? And from there, it was just phone calls we started having with those physicians. With us in Missouri, looking specifically at diabetes populations and blood pressure populations, we did focus our attention to internal medicine, family medicine, as well as endocrinologists and cardiologists. So casting still kind of a fairly wide net. And at the time I left, we had one clinic that we were really connecting with and starting to get more of their patients referred to us for that service. And so really just kind of knowing who are those mutual patients, what can you do for that provider? How can you help to reduce some of their workload, but also making sure they understand, okay, I need you to pay for this service I'm providing as well. If I'm taking a 30-minute consult out of your office that you don't need to worry about, I mean, you're getting paid $500 to do that consult. the pharmacist doing that then too is not going to do it for free, but needs to be paid. So a strict part of our conversations were always, okay, we are doing this service, but what's that payment going to be look like? We need that to be formalized and understood by all parties before we could move forward with any sort of agreement. So kind of negotiating what that looked like was a little bit different for each provider that we talked to. In some stages, it did cause that provider to walk away. And so I think one of the things moving forward, pharmacists really need to continue to do is explain what their worth is, and then how not only is it going to benefit the provider, but also the patient, and how can we really streamline healthcare. Guess what questions do you have about that, or any questions regarding that?
I'm kind of curious. You were
Yeah.
speaking about starting a project in the rural area.
Yeah.
How large did you say that population was?
Or sorry, I
Just
get cut off there. What was that population?
how large was that population?
Oh,
Yeah.
yeah. So Makokata itself has a population of about 5,000 or so. But there are so many tiny little farm towns around. Like Sebula is one. Gosh, now I'm struggling to think of what some of those all were. But it extended out that our delivery driver, when he went on deliveries, was delivering probably almost 8 or 9 different communities, each spread by, in Iowa, measuring by time, but 15 to 20 minutes from Makokata. And so it was a fairly extensive area in which we were serving. And I remember one phone call with a patient. He had taken his blood sugar at home, and it was something kind of crazy, like 300 or so. And I was asking him about his insulin, and when was the last time he had used his insulin. He's like, well, I haven't been able to get to the pharmacy. I don't drive. It's been a week or more since I've used my insulin. And so in that moment was kind of one of those times where like, okay, well, delivery service is something we need to be expanding or trying to expand potentially. Education to this patient about why that is problematic to miss doses of insulin is important. And then education to the patient about how moving forward we could try and avoid these non-adherence episodes, or what we could do to help them acquire their medication was something we had to do. So we ended up scheduling that person onto a medication adherence schedule. So we were doing a little bit more conversing with the patient on a regular basis to ensure that they had the medications they needed to avoid those complicated situations. So all in all, I mean, thinking of that patient encounter, it was probably an hour or so of work. But once we got them on the medication adherence schedule and started packing their medications, that looked like about a $40 charge each month with the follow-up there. So bringing in a little revenue as well, since we did get them on that plan.
Yeah, that kind of just sparked some interest in me because I'm from very rural Northeast Iowa.
Yeah.
And the whole idea of just not having that access to healthcare is what drove me to pharmacy.
Yeah.
Because we're like dab in the middle between Mayo, Rochester, and Iowa City.
Yeah.
And nothing in between.
One of the things I'll be very interested in seeing is they have a resident at that site right now that was looking at a project that involved potentially pharmacists going out on some of those deliveries and meeting the patient where they are. So going into the home, potentially doing blood pressure checks, like A1C assessments, that education in the home rather than in the pharmacy. I have not seen the end result of that project yet, but I know that was something one of their residents was looking into, and I think will be really nice information to hear a bit more about, and where there's maybe a space to create a service around that of kind of bringing back the old home visit arena. And is that something that where pharmacists could play a role? And I think there certainly is potential there, meeting the patient where they are rather than having them come into the pharmacy. But again, always having to think about what that cost looks like. Having a pharmacist you're paying that's not in store or in like the site, thinking about travel expenditure, et cetera. In the way community pharmacies stand right now, if that were to move forward, you would obviously always have to have two pharmacists on staff, one to stay at the actual location, one to go out on those home visit calls. So some complicated things to think about there that I'll be interested to see what the results of their study kind of found. Yeah.
Cool. So, yeah, in addition to some of the services that I talked about in the beginning slide, I do want to elaborate on what cash only pharmacy actually means. So basically it means what it means. It's cash paying, no insurance. So insurance, it's a very touchy topic because when we think about insurance, we're paying for insurance. Oftentimes we want to get the most bang for a buck when we're paying for a service like that. But the way we kind of explain it to people, specifically as it relates to like cost plus for getting generic medications at a cheaper cash price, is that insurance is best for catastrophic events. Kind of like you use car insurance when you get in a car accident and you have a very expensive claim. Insurance has to pick up the deductible and then it picks up everything else. Interesting thing with that, your premium usually goes up after that too. So we'll talk about that as it relates to like employer groups too who are offering insurance. But ultimately, for those cheaper expenditures, what we've been finding is that when you pay the cash price for a generic drug, it's oftentimes cheaper than what it would be if you would go through the insurance carrier, which is very interesting because it's been ingrained in our head that when we use insurance, we should have a cheaper price. That's why we pay for insurance. There has been a lot of unrest, I should say, with like an insurance, because if you look at your insurance companies, they're just been vertically integrating, and they're turning in the PBMs are now insurance companies, which are now owning pharmacies, which are insurance companies, and there's a lot of conflict going on there. And so what we try to do with the cost plus is we're just cutting out all the middlemen. And that's when you find out the cost savings can be dramatic. And so what we've done for not only offering that to just general people, which by the way, I think that in the next few years, a lot of people are just gonna be like, hey, I'm in on cash paying for prescriptions. Like I'm not interested in paying or utilizing insurance for that. It will be interesting because right now we have like these terms of generics and then brands and then specialty drugs, which a specialty drug really doesn't even mean much. Like you can get on the specialty list without being all that special. But in the future, what we're probably seeing is generics and specialties. So generic drugs are oftentimes probably going to be purchased at cash, and specialty are probably going to require some sort of insurance or some sort of payment method for that. If you actually look back 20, 30 years ago, we actually didn't have insurance, which isn't that long ago for prescription drugs. Like we did not have, people would go to the pharmacy and they would pay the cash price for prescription drugs not that long ago. And then when we introduced like Part D and then other plans, it just got abused to the point that pharmacists were getting reimbursed very, very low amounts. And it used to be low and then it just got lower. And now it's gotten to the point that it's sometimes $0. Sometimes it's even we owe back. It doesn't make any sense. So the idea here is we got to take back the profession that we believe that Amy just said. We are valuable. We need to explain to people that we are valuable. You don't find me to be valuable if you're making me pay you for my time and my service, my expertise. You certainly are making me feel valuable if you're giving me a $0 reimbursement. And although it sounds odd, that has happened time after time after time again, all over the entire country. And not to be the Debbie Downer, but that's going to be the prime reason why we see a lot of community pharmacy sites close in the next 6 months or so. So what does that mean? I see those types of concerning behaviors or concerning things going on as opportunities, because in order for you to be a viable pharmacy now, it has nothing to do with the drugs. I am a business owner first and a pharmacist second because I can't pay my pharmacist if I don't make enough money to pay the bills. So I have to think about the business side first, and what that typically means is how we generate revenue. So that's where those consultations come in, where we pay or that we charge cash prices. That's where we do our due diligence on getting OTCs or nutraceuticals that are going to actually make a difference in somebody's life, and we charge for that. Lab testing, we charge for that. We don't just give these services away anymore. With Cost Plus, what that looks like is it's such a transparent relationship that we actually charge them the national national average drug acquisition cost, which is NADAC, which is publicly available on Medicaid.org, and then we add $12 to that. And the reason why we do $12 is because that there was a study put on by NCPA a couple years ago, National Community Pharmacy Association, that said in order for a community pharmacy to pay for their pharmacists, including the operational expenses and the overhead and everything that goes in, like the bottle on the label and everything that goes into a prescription drug dispensing, you need to charge $12 in addition to the cost of the drug. So, I mean, that's why it wasn't just arbitrary, it wasn't random. There's a science behind all this. And that's what we show with the patients, why we're charging them $12 and why that is added on top of their prescription drug fee. But the nice thing about it is I'm buying generic drugs for pennies on the dollar. I can buy a 30-day supply of atorvastatin or lisinopril for 47 cents. And then if I charge $12 on top of that, their copay now is $12.47. Oddly enough, you'll see people getting charged copays of $30 or $40 for these drugs. And it makes absolutely no sense. But then when you look at the wealthiest companies in America and recognize who they are and where their place is in healthcare, and then you wonder what the heck they're even doing to provide value, your red flags start going up. And if you're like, if I can just cut them out, that's how I save the patient's money. So I see that type of service offering going to continue to evolve over the course of the next, probably near couple years. A lot of people are probably just going to opt out of doing generic prescription drug insurance. And so that's going to just continue to grow. And so that's how we make it so the pharmacies who did end up dying out because they're not interested in changing their workflow or their model, their business model, the ones who do remain need to adopt these different kinds of pharmacy business. What I tell our staff all the time is in 2 to 3, I have no idea what 2 to 3 years is going to look like. I'm focusing on today and next week because that might change pretty rapidly. But in 2 or 3 years, the idea of a community pharmacy might actually look like I go to the pharmacy to consult with my pharmacist about the medications that I take, but they don't give me the medications. I get the medications elsewhere because, like I mentioned, there's no future for reimbursement of prescription drugs. That just probably will never occur. We can do all the advocacy that we want. We can fight for that better reimbursement, but there's just one thing on top of another that just keeps on occurring that makes it so getting reimbursement for prescription drugs probably won't happen again. And that's why it's so important as a pharmacy student, as a new pharmacist, or as an ongoing pharmacist who's been in the field for so long, not only to be able to show your worth, but being able to create something new from scratch or from an area that doesn't even exist yet. Because if you're not able to do that, you might be in a situation where you're trying to do the old model of dispensing drugs and nobody's hiring for that because nobody's getting paid for that. So that's why it's so important to ask about how I can get engaged and involved in different types of services. So if you don't ask, you just might not ever find out. That's what Amy is talking about with, reaching out to providers and talking about collaborative practice agreements, reaching out to patient demographics that might be an eligible patient for a unique service that we might be able to offer. But if we just kind of stay quiet and say, here's your atorvastatin, yeah, I just lost $5, that's great, and do that time after time again, what business survives doing that? It's like going to the grocery store and buying milk for $2 and it costs them $4 to get the milk on the shelf. Nobody would do that, right? And so we need to be able to show our value and express that not only to patients and providers, but the biggest one is payers. So when we talk about provider status, it's kind of a term. I know when Amy and I were back in school, it was a really big popular term. Nowadays, you might talk about it here and there. It's a little less popular, but still an effort that we're trying to gain is pharmacists being recognized as providers by CMS, by Medicare and Medicaid, so that we can bill for our services. And a unique thing to know is that a lot of pharmacists are saying, hey, I'm going to wait until they give me that provider status, and then I'm going to start practicing at the top of my license. I'm just going to wait. And then they're like, hey, you're giving you provider status. Then I'm going to start billing for all my time because I have all this expertise that I haven't really utilized in the last couple of years, but now I'm ready. And it doesn't work like that because you need to be able to display and showcase your skills for that payer to come. And so when that payer is ready, you can then easily create a demographic for or create a service offering that will help patients, get better health. And so what that looks like from CPESN, it stands for Community Pharmacy Enhanced Services Network. That is a network of community pharmacies that have more leverage than just, one small local independent pharmacy trying to talk to a payer. But if we have this network of high performing pharmacies, we can go to a payer and say, hey, this is something that we could do for your patient demographic to make your expenses go down so that your patients can be healthier and so that we can save you money. And, one of the first things that we always ask any payer or any decision maker in this space at our initial conversations is, what's the number one modality of healthcare? Is it surgery? Is it physical therapy? Is it medication? It's medication. That's obvious. Everybody's on medication. Some people are on 6 to 8 medications. And then we ask them, okay, what's the number one related healthcare expense? And a lot of people don't really know the answer. Like, surgery? That seems to be pretty expensive. And the answer actually is medication related adverse events. And what we tell them is that is a huge opportunity for pharmacists, because I know, especially as a P3, I know that you've been told your pharmacist is the medication expert. APHA is a big believer in saying pharmacist, medication expert, know your pharmacy, know your medicine. So if we're the experts in that space, and we know the number one modality of healthcare is prescription medications, and we know the number one expense to healthcare is prescription adverse events, that's our domain. We just found our opportunity. But we need to then reach out to these providers and these payers about what we can offer. And until they know that information, they might not even consider us as somebody who's going to be even worthwhile talking to. But when you explain that to them and then talk to them about different services that you can do as a pharmacist beyond just putting that drug in the bottle and throwing a label on it, like I said, I don't want anything to do with prescription drugs and having them in my pharmacy because I'm losing money on them. But if you can talk about all these other things, you open the doors to huge opportunities. And that's what provider status is going to look like. It's not going to be like one day a payer or CMS is going to be like, all right, here's provider status. It's going to be, let's see how we can ease pharmacists into being providers of healthcare. And perhaps, I don't know what that might look like. Maybe you need to be board certified. Maybe you need to have X amount of years of experience. I don't know what that's going to look like, but it's not going to look like dispensing drugs. I can promise you that. And that's why we tell people, start doing the things that you need to do now as a student, as a young pharmacist, as a pharmacist who's been in practice for 10 years, 20 years, whatever it may be, so that when provider status hits, it's easy for you to start billing for your time. So with CPSN, like I talked about, right now we're involved in this Carillon RX project where a payer is identifying patients that they have under their subset demographic, and there's identifying the pharmacies within CPESN to work with these patients on asthma, diabetes, statins, adherence, and talk to them about asthma, diabetes, statins, adherence, and talk to them about the medications, talk to them about lifestyle behaviors as it relates to diabetes, talk to them about how we can get better maintenance medications as it relates to asthma and not just having to use rescue inhalers all the time. Talk about who's an eligible candidate for a statin medication. Talk about how we can improve adherence, because a prescription medication is only as good as it's being taken. So if we can get you on the right medication list and you got all the right medications and you take them once a month, guess what? You're probably winding back into the hospital. And guess what? Who pays for that? Payers. And that's what relates to number one expense being medication-related adverse events, whether it's a side effect, whether it's non-adherence, whether it's a drug interaction, because quite frankly, just because they're on a prescription medication regimen doesn't necessarily mean it's the right prescription medication regimen. So they need to have safe medications and efficacious medications, and they need to be producing an outcome. Because if they're not producing the desired outcome of what we're intending to be on, for taking blood pressure medications and I'm still skyrocketing my blood pressure at 155, 160 over 90, I'm clearly not on the right regimen or something's going on here. Maybe it's pharmacogenomics. Maybe I need to see if your metabolism of this drug is not appropriate and you need to be on you're a better candidate for a different drug. These are all the things that need to be going on in the pharmacist's mind to make sure that they're just not on prescription medications to be on prescription medications, but they're on the safest, most effective prescription medication that is going to produce an outcome to reduce hospitalizations, unwanted physician visits, emergency department visits, and guess what? Overall healthcare expenses, because that's when provider status becomes valuable. But it doesn't just happen by saying, I'm gonna wait here, sit in my chair and wait for CMS to give me provider status, because it's not going to look like that. And so these types of projects, by getting involved with CPSN, but also just talking to other payers, being okay and willing, I mean, like I mentioned, throwing out 1,000 emails, throwing out 1,000 text messages, messages on LinkedIn, no, 1,000 people are not going to respond back. But if 10 do, you have 10 opportunities there. And that's how this can develop into a much bigger opportunity with provider status and pharmacists being able to practice at the top of their license and being able to bill for their time. So in that CPSN project, Amy mentioned e-care plans. That's kind of a way for us to be able to attach our documentation and attach that to a. Can you guys see me right now? All right.
Yeah, we can still see
Okay.
you. Sorry.
My Zoom just like crashed on me. But that's how we're able to attach documentation to a service offering to a SNOMED code that is going to be a billable code in the future. But until we're able to do that time after time after time again, it's not going to be someday we'll wake up, we have provider status. Now I'm trying to figure out SNOMED codes and e-care plan documentation, because it's really not super easy. It takes a lot of practice to get involved with that. But when you look at how medicine is practiced, these are the types of things that they're billing for: time, service, and how you document those codes, billable codes, and tie them to the service that you offered. And then that's how a physician, nurse practitioner, whoever it may be, gets reimbursement for their services. That's what pharmacy is going to look like in 5, 10 years. I don't know what the timeline looks like for that. But until we start practicing that way, it's not going to look like that everywhere. So that's why it's so important for us to all get involved in it and all practice at the top of our license and not just wait until one day CMS wakes up and they give us provider status, because it's not going to be easy then. What questions do you have in regard to that?
I don't think I have any questions. I feel like I'm actually like super inspired, and now I want to like change and come up with something, like you did.
Yeah.
But I totally agree. As especially people in my position right now, just about to graduate, start their careers, we need to stop waiting on the sidelines for the career to catch up to us. We need to start things. We need to push for these, advocate, go to Congress people or CMS or wherever it is, and get this ball rolling, or else it's never going to happen.
Absolutely. What I always say is your biggest barrier is yourself. If you're going to do it, then you're going to do it. And if you're going to kind of have that negative self-talk, like, oh, maybe I shouldn't reach out to that congressperson because I'm going to sound silly if I mess. They have no idea what the heck's going on. There's no way that you could say something silly and they would be like, what the heck is she talking about? You could say the most outrageous thing about prescription drugs. They'd be like, oh, okay, let me write that down. You are the expert in that space. So if it's talking to a legislator, don't feel concerned about saying the wrong thing, because you are the expert, whether you're a P3 or a P1. Like, a couple weeks in a pharmacy school, you got enough information to be able to talk to a legislator. So yeah, I mean, just getting involved, and not being afraid, I think is a big one too. Uh, I mean, when I was a student, I think it's imposter syndrome, right? When you're like, ooh, am I a good candidate to be the person? Maybe I'll just take the back seat and let someone else in my class do that. And then once they get the ball rolling, maybe I'll jump on there. If everybody has that mindset, we're not going to move anywhere together. So I think everyone needs to switch their mindset and their frame to thinking, I got to be the leader in this. I got to be the person that takes the step forward. I got to be the first person to this. And that way you can get everybody momentum and get everybody on the same page and create a really valuable opportunity for not just yourself, but everybody in the profession. But it requires a lot of people, not just one person. So I think just, starting with yourself and then just encouraging other people and then getting the word out there. As you mentioned, talking to legislators, talking to other constituents, letting people know what your worth is as a pharmacy student, as a pharmacist, even non-pharmacist support staff. Technicians have a fantastic role in this as well, especially as it evolves. Even like delivery drivers. That's actually going to be a big thing. I don't think we talked about community health workers too much. That's going to be a huge thing as it relates to social determinants of health, non-medical, non-prescription related health care, or things that can actually contribute to somebody's health and well-being. And utilizing non-pharmacist support staff is going to be a very unique opportunity there too. Obviously, the whole thing will be driven by pharmacists though, and then having them teach the non-pharmacist support staff what that would look like too. So yeah, I think as a P3, super exciting times. It's going to keep, I think actually, as I tell my students who work for me right now, being a pharmacy student and this time is kind of cool because you're kind of a student when all this reimbursement baloney is going on. And hopefully in a couple of years, by the time you graduate and are into the field, we're kind of into better, bigger and better things. And you don't have to worry too much about this terrible reimbursement and the Pharmageddon and all the terrible things that are going on in the news right now. But the opportunities will always be there. You might have to create them, or you might have to be, bold and take the first step forward. But being a pharmacist, that's not going away. There's no Pharmageddon's not taking away pharmacists. It's just going to restructure and realign what it looks like.
Right. We just have to get over this like intrapersonal barrier of being afraid of change and all of that and be able to change the field of pharmacy themselves.
Right. And, it's not just, yourself, because if we have that fear of change, you can imagine the other people who don't even know what pharmacists do. We know what we do. But if other people who have no idea what we do, and if we can't explain to them what we do, then that's going to be the challenge. So yeah, exactly. Getting over that fear of change, but then telling the other constituents, hey, this is something we can do, and this is something that's going to benefit you and your practice and your patients.
The one thing I did also want to add, just as I have kind of in a unique position being within the College of Dentistry and really working with dental providers, is the worth that pharmacists have. We've talked a lot about talking with MDs, with PAs and NPs, but really it extends so far beyond that. And so I'm integrated right in with the dental clinics. And right now we're an N of one in the colleges of dentistry with pharmacists working in the clinical setting. But we are starting to see more and more dental schools involve maybe pharmacy faculty on board. And so I think that that is even a unique space for pharmacists to get involved in, say, the dental space, the surgical space, dermatology spaces, where it's not just those units within a hospital, but your ambulatory clinics as well. And so if you have a niche area you really like to focus in, it doesn't have to necessarily be a hospital system. Kind of talking about your worth, what you bring to the table in any setting is worthwhile.
Jenna, do you have any other questions for Amy or Aaron?
I don't personally, not right now. I probably will. in the
Well,
future, but I know how to.
thank you for joining us today. It's a win-win in my eyes because you get some one-on-one time with our Genesis board members. So, um, thank you for joining us. And Aaron and Amy, thank you for presenting. I learned a ton of stuff, and that's great. Kristen, thank you for joining us too. Did you have anything to add to the conversation?
Gosh, I just have to say how I know that you mentioned this too, Jenna, but it really is inspiring. I work in, a hospital clinical pharmacy setting, and to get to hear the things that my colleagues are doing is just really exciting and really great. And I think even someone who's been out of school for a few years, gosh, it's a little bit more than a few years, but it's okay. Getting to actually, hear about all the cool things that are happening and, hear how the profession is changing in a lot of really positive ways and in a lot of exciting ways. I just think it's great. It's great whether you're a student or, years down the road, connecting and staying connecting with a group like the Genesis board is really beneficial to hear about all these different types of opportunities. So shout out to you, Aaron and Amy. You're doing some really incredible things that, really unique. I feel like not a lot of people can say that they're doing something even remotely similar to what you do, and it's very inspiring to hear.
I did
Thanks,
want to
Kristen.
mention that, Jenna, we have our last, perhaps, SuccessRx next Tuesday. Announcement will be going out about that. It is mainly focused for P4s, but I am going to be inviting everybody to it. And it will be about difficult conversations, specifically about salary negotiations. So maybe something to put away for next year when you're in the position. We'll probably have it next year also, but I encourage you to attend. Please reach out to your friends and encourage them to attend as well. It's a great way to network with our board and make new contacts. With that, do you guys have anything else to say?
I do want to put a plug in for our icon site. If you haven't had a chance to look it over, we do have a little discussion ongoing there that will open here in just a few minutes. And so we're hoping to continue that conversation, even with those who weren't able to attend tonight, about what are some of the things we can do to continue moving the pharmacy profession forward. And you heard a lot about community-based pharmacy today from Aaron and I, but we look forward to talking about lots of other things too. There, all Genesis board members will have kind of an opportunity to offer some insight there. So I encourage you to check that out, make comments as you see fit, and we look forward to continuing to work with you in your pharmacy endeavors.
Thank you both.
Thank you very
all.
much, Amy.
Yeah, thank you, Jennifer, for being the lone wolf tonight. It was awesome being able to talk to you one-on-one though.
Yes, thank you.
To have you guys here, even though it was just me, but it's very helpful and nice to know that we have support.
Absolutely.
And you do. Tell your friends that too.
Yes. All right. Well,
okay. Well, I hope you guys have a wonderful night. I don't even know what the score of the game is, but you can turn on your TV and watch the game now.
Thanks, Kayla. Have a
Have a
good
great
night,
night.
Thanks,
everyone.
Kayla. Have a good one.
Good night. Bye.